I'm going to be talking about managing adverse effects of androgen deprivation therapy, and you'll hear in my comments reference to lots of topics that are covered throughout the day. So forgive me if I go through things quickly, because there's really an in-depth coverage of many of the topics that I'm going to be talking about that we've already heard and that we'll be hearing throughout the rest of the day. I will say I didn't have a chance to introduce myself before, or didn't take that opportunity. So let me just say that I'm the Medical Director of Palliative Care here at the Cancer Center at the Helen Miller Family Comprehensive Cancer Center. So I run our palliative care service, and I have the opportunity and the pleasure of working with a number of folks in the room, as well as a number of our presenters. So I'm going to be talking about adverse effects of androgen deprivation therapy. So I'm thinking about side effects as well as risks and the disease itself. So really trying to manage all of those things. And we're going to be talking about three general adverse effects, sort of three themes. The first one is cardiovascular. You're going to hear about that in more detail momentarily by our next speaker. But if you think about some of the effects of androgen deprivation therapy, you can understand how it impacts cardiovascular health because of the tendency for weight gain, because of the influence on our cholesterol, and because of the influence on our insulin, so the creation of prediabetes or diabetes. So much so that we see significant worsening of cardiovascular morbidity and mortality through the diseases that are all so common for us already: hypertension, myocardial infarction, sudden death, heart failure, fatal arrhythmias, and stroke. Cardiovascular effects of androgen deprivation therapy, as well as other therapies in cancer generally, are such an important and significant topic that there is a relatively new field, a well-established field of cardio-oncology, and we have one of the world's experts who's going to be speaking to you about that momentarily. The second theme is the hormonal effects of androgen deprivation therapy. So thinking about osteoporosis, or decreased thickness of the bones, or bone density. The skeletal fractures are a really dreaded complication of thin bones. Loss of muscle mass, breast enlargement, which is actually incredibly common, 70% of men, because of the hormonal effects of decreased testosterone. And then hot flashes. Up to 80% of men might experience that initially, and 40% might persist with hot flashes. And importantly, a significant minority of men report hot flashes as one of the worst symptoms that comes from androgen deprivation therapy. And I see a few heads nodding in the room. Yeah. And third is a big category, a really important category, which I've titled vitality. I'm not sure that there's a lot of the use of that word in the literature, but that's a lot of what I hear described by many men. Really generalized quality of life concerns. With androgen deprivation, many men will report fatigue, which may be the most common complaint of men who are suffering from side effects or adverse effects of androgen deprivation therapy. We see changes in sleep, and we see changes in erectile function, which Dr. Breyer has just finished talking about, as well as the accompaniment of low libido. So there's the biological or pharmacological, physiological functioning, and then there's the desire, the libido. Emotionality generally, some men find themselves crying at, Clorox commercials on TV, which doesn't make any sense for many of us, but there is often a general increase in emotionality, and sometimes we see frank clinical depression or other diagnoses, psychological diagnoses. And then a sort of general sense of brain fogginess that can come with androgen deprivation. So the bulk of what I wanted to say has to do with the strategies to deal with androgen deprivation therapy adverse effects. We can sort of preempt some of those by having men get less androgen deprivation therapy. So a really personalized approach, interrupted approach rather than a continuous approach, less dose, less duration of the exposure, and that's something that you're going to be hearing about throughout this day. Really personalizing the therapy to maximize the effectiveness of treatment and balancing it with the side effects or the adverse effects. I'm going to be talking about the mitigation of those adverse effects and what we ourselves as patients and people who love patients can help do around minimizing the adverse effects. So I'm going to start with, and this is truly the most important part of the talk, this idea that we can manage the effects of androgen deprivation therapy through our behavior. And I put it in parentheses, but it's really, really important to recognize that the behavioral things that we do are both safe, safer than any medicine, and they're effective, as effective or more than medicines. So I know that it's easy to prescribe, it's easy to take medicine, and they have very, very important roles in managing the adverse effects of androgen deprivation therapy. But it's really the behaviors that we should think of as number 1, 2, and 3 for where we should turn to initially and in an ongoing way. So we're going to be talking about 2 primarily, cognitive behavioral therapy and physical activity and physical therapy. So let's look at both of those a little bit. So physical activity, if you take one thing away from my few minutes and perhaps from much of this day, it should be to keep on moving. We probably should have this conference with everyone on treadmills because we're all doing the wrong thing today, which is spending a lot of time sitting. So make sure throughout your breaks and after this, and then for all the years after this, that you spend as much time moving as possible. Move around. That's the one thing that after these 30 years I've been practicing medicine, it's the most important thing that I've learned is that I just have to keep on moving, even if I don't really want to, even if it's raining, even if it's cold, to keep on moving, yeah. So we think about aerobic activity, so moving, increasing your heart rate, and we think about muscle strengthening, so carrying the weight of your body and other exogenous weights around to increase strength. Physical activity helps with many of the symptoms that I was describing: fatigue, sexual function, quality of life, metabolic syndrome, cardiorespiratory fitness, incontinence, bone health, and muscular strength. So if you saw that list and you say, wow, movement, physical activity seems to help what ails me, you are correct. That is my point. Exactly right, yeah. The second big category is cognitive behavioral therapy. And just a show of hands, how many people have some sense of what CBT is? Yeah, so maybe about half the room or so. The other half of us need to learn it because it's super important. And I would summarize CBT, cognitive behavioral therapy, as don't believe everything you think. Because our thinking influences our emotion, our thinking influences our function, our thinking influences our ability to optimize the quality of our life, yeah? So sometimes what we're thinking is correct, but a lot of the time, what we're thinking about, and then what we end up worrying about is not correct. What we're thinking about often ends up not being true. So don't believe everything you think. So CBT is the process of learning that your thought is just a thought. Maybe your thought is just a worry. Maybe your thought is just an unrealistic worry. And so we can challenge our thinking through education, through reading, through support groups, through talking with your healthcare team, yeah? So cognitive behavioral therapy obviously involves thinking, that's the C of cognitive behavioral therapy, but it involves behaviors as well. And the behaviors I'm talking about are the things that you do to improve your health. Sleep, exercise, diet, challenging yourself to be exposed to things that you're maybe scared of. Yeah, so exposure therapy. So we can both adjust how we think, we can sort of fix how we think, correct how we think, and we can do all sorts of things to help improve our health outcomes, including just relaxing. And I say that with a bit of irony because I know it doesn't work to tell people just to relax. Stop worrying. I know that doesn't work. I know it doesn't work. But there are formal ways through guided interventions with therapists or through reading or through meditation where we can achieve this. CBT is covered by insurance, generally. It's available not as widely as it needs to be, but it's available here in the Cancer Center through our psycho-oncologists. And psychologytoday.org is a website where you can go to enter your zip code and find a CBT therapist who might be able to help you. Yeah. So I'm going to essentially run through the next few slides. It's a whole long list of medicines that can work for various symptoms. And I encourage you to be open to medicines, but to have, at the baseline, really paid good attention to your lifestyle, to your physical activity, and to how you are thinking about things or not thinking about things. For bones, the goal is to decrease our risk of osteoporosis, and your oncologist or oncologic surgeon are going to be key here thinking about that. So we have treatments including calcium and vitamin D, which are often necessary but not sufficient to treat osteoporosis. And Terry Friedlander is going to be speaking to this a little bit later in this session, but we have bisphosphonates, denosumab, and the serotonin estrogen reuptake regulatory medicines that are super, super helpful, super, super effective, and have a huge role for people who have developed or are at risk for osteoporosis or skeletal fractures. Treating depression, we know, is best done through a combination of therapy and medicine. So when you ask your doctor if there's a pill for this, it's almost never the case that that is sufficient. Yeah, we usually want a combination of therapy and medicines, and the classic serotonin reuptake inhibitors and norepinephrine reuptake inhibitors are typically the treatment. Hot flashes, something that we talked about as being very important to many, many people, have a long list of medicines that you see listed there. Really, really important, and I would say important to talk about it with your clinical team, because it's hard for us to treat something that we don't know, and for sure we have a responsibility to ask you about it, but if for various reasons we don't ask about it, it's something for you to know to bring up because there's good treatments for it. Cardiovascular risks. We're treating cardiovascular disease very similar to how we treat cardiovascular disease from any cause, thinking about treating our hypertension, our cholesterol, using aspirins, and even intervening on this. And I guess the main point I want to make here, which is actually not on the slide directly, is that the troubles from androgen deprivation therapy in terms of our cardiovascular health can start within months. So we should start thinking about monitoring these issues, assessing these issues quite soon after starting androgen deprivation therapy. And then for fatigue, the number one treatment for fatigue is exercise, but sometimes we can use other medications like methylphenidate to help. And then for sleep, again, behavioral interventions are the number one treatments, but sometimes melatonin as a supplement can be helpful. The take-home point that I want to leave everyone with, however, is that all of these issues are the result of good communication with your clinical team and shared decision-making. We all bring our expertise to this discussion. Your doctors and nurses and social workers and other folks may have their expertise, and you're going to bring your expertise around what matters to you and how things are impacting you in your life. Yeah. So communication amongst everyone is important. We know that the ultimate decisions come from understanding what the goals are, from what matters most to you. I don't want to be treating something that doesn't matter to you, and I absolutely want to make sure to attend to things that are super key to you. So your priorities are key. And keep in mind that your sense of what's most important to you is going to change over time. It does for all of us. And it's going to change based on our age, just our chronologic age. It's going to be based on the seriousness of our cancer and perhaps our prognosis. It's going to be based on our lived experiences of things. Perhaps you had no sense of what hot flashes meant to you until you had your first hot flash. Yeah. And over time, we know that your priorities and your goals are going to change. And so these are conversations that need to be had early, immediately, but then they need to be repeated over and over and over again throughout the course of your life as things change and as your sense of what defines a quality of life for you changes as well. So thanks very much.